Welcome to the LearnSkin podcast with Dr. Raja and Dr. Hadar, where they discuss all things skin. Skin is fascinating because it affects us in so many ways, like our health, psychology, and how we connect with those around us. This podcast delves into the art and science of skincare. A short disclaimer before we get to the good stuff. Dr. Raja Sivamani and Dr. Hadar Levtov are board-certified dermatologists. This podcast is meant for educational and informational purposes only. All opinions shared do not express the views of LearnSkin. Neither this podcast nor any information contained within it are a substitute for professional care by a doctor or other qualified medical professional. This podcast does not constitute medical or other professional advice or services. If you have a medical concern, please consult with your physician.
Hey Raja, how you doing today?
I'm doing great.
I've been thinking about this case on and on. I've had these patients who come into me with acne, run-of-the-mill acne, simple acne, adult females usually. We see them on and on every day. And they keep coming and saying, I don't want antibiotics. They give the side effects. I don't want to be on them for a long time. And we know that there are recommendations to try to avoid use of antibiotics because of resistance and other issues. And, do you find that you have difficulty figuring out, okay, what do I do with this patient?
Well, pound for pound, dermatologists put out a lot of antibiotics, and I think acne, a chronic condition, is a challenging one. Luckily, you and I don't have to figure all of this out because
really?
we have a guest today on the show, Dr. John Barbieri from
Lucky
Utah.
us.
Yes, lucky us. And he constantly thinks about this question of antibiotics. So let me go ahead and introduce John. Welcome, John, to the show, and we are excited to have you on our podcast.
Yeah, thanks for having me.
John.
We'll see if we can make some progress on these challenges.
Yes, absolutely. And I think we should dive right into it because, gosh, this is a question that bugs a lot of my patients. And certainly when I talk to my colleagues, they're they think about this quite a bit. And I think it's a testament to dermatologists that we are trying to be cognizant of this. But I know that you've looked into large data sets and tried to look at the usage of antibiotics for acne and other alternatives. Can you tell us a little bit about antibiotics use and what you found?
Yeah, and I think an important just baseline to understand is so dermatologists, they prescribe about twice as many antibiotics per provider than any other doctor when you just look across medicine. So we're
That's
big
unbelievable.
using antibiotics. And when we look at that use, about 60% of the chronic courses that we're prescribing are for acne. So this is a big area where we're using a lot of antibiotics to treat our patients. And many of them need it because acne can be challenging to manage for patients who have moderate to severe disease.
Yeah, and I think one of the things that, to be mindful of with dermatologists, the reason we use antibiotics is because they work, and they work for acne. And I think all of us would love to switch away from antibiotics as soon as we get another viable option that wouldn't have to put us in a position of having to prescribe antibiotics. And I think that's always been the challenge. So, and John, you've really looked at this closely, haven't you? I mean, it looks like you've really looked at antibiotic use in general and what people go to first line. I mean, can you, and you have some very nice publications that you've put out on this topic. Do you mind just taking us through at least what you found in terms of antibiotics and where we stand with that?
One of the first studies that we did looking at this topic was just trying to understand the general prescribing patterns like we were describing. And so just let's take, for instance, women with acne. There's a couple of different options that you could have to treat a woman with moderate to severe acne. You could use antibiotics. You could use combined oral contraceptives. You could use spironolactone. You could use isotretinoin. When we look at the data, antibiotics are by far and away the most common treatment used in that group. And they're actually used about 5 times more commonly for women with acne than the next most common alternative, which is spironolactone. And, when you start to look at that, it raises the question of, could these other options, could we use them as substitutes for antibiotics? We all know about the issue of antibiotic resistance in the community, but also at the individual patient level, the more we learn, the more we start to realize there are potential impacts on our individual patients. Patients with acne who are treated with antibiotics are more likely to get pharyngitis. Potentially there's an increased risk of inflammatory bowel disease in this population with chronic antibiotic use. There's even some large population studies that suggest that chronic antibiotics exposure can predispose individuals to breast cancer and colon cancer potentially. So these are all important considerations where we need to think about what other alternatives could we use and what might work just as well.
Thank you. Yeah, and I think it's important to remember that the recommendation is to treat with oral antibiotics for about 3 to 6 months the most, and see what kind of effect you get, and then change from that. Have you found that to be true in your investigations?
Yeah, so when we look at what's actually happening, many patients get treated for quite a bit longer than 3 months. So about 50% of patients in the US get treated for longer than 3 months, almost 20% longer than 6 months. Some other data sets we've looked at in the UK, it's even more that are getting treated for prolonged courses of 6 months to even a year or longer.
Right.
Yeah, I mean,
I think, we've looked at this in rosacea, and one of the things that we've proposed is that combination therapy is probably utilized quite a bit in practice, but not really well studied. What I mean by that is when I start a patient on antibiotics, I immediately start them on a topical. And depending on how complex I want to make the regimen be, but right now that's not important. What's important is that I start some kind of a topical and I build on that. So when they come for their follow-up visit, they're still getting the benefit of the systemic therapy, but also I put in maybe an additional topical and then slowly can transition them. And that's, I think, is an important practical tip to remember. So you can actually stick to that guidelines, because the guidelines say stop after 3 months. They don't tell you what to do after those 3 months.
Yeah, and we do have some evidence that using concomitant topicals in acne, like a topical retinoid, can help decrease the chance of relapse when discontinuing antibiotics. Although the other thing about these guidelines is when you really look at the data, we don't know that 3 months is the right answer. For all we know, 3 days the damage is done, 3 months, maybe 3 years. And maybe it's about minimizing the number of patients we treat rather than arbitrarily trying to limit the duration. There's some interesting microbiome work that's starting to come out. There's just a recent study a few months ago trying to look at in individual patients what happens to their microbiome and what are the time courses of these changes. That's an area where we definitely need some more data to understand, is 3 months really this golden rule, or should it be a different number?
Yeah, it's a very good point. In fact, we did a study looking at, and this is unpublished, but we did a study where we looked at doxycycline in the gut microbiome. And even after 1 month, we had changes that lasted for multiple months afterwards. And so yeah. I think it's, and this is in the gut, and we don't know what the clinical implications are. That's, of course, the next step. But, I mean, there are changes. And I think the 3 month rule, tell me what you both think, but I think the 3 month rule is just because, sometimes it takes a while for the antibiotics to kick in. But gosh, wouldn't it be great if we could give them another medication at the same time, or something that could be a substitute so you could pull it off even earlier? I try to pull it off within 2 months if possible.
Yeah.
It's a challenge in some cases. But
and honestly, in my practice, I almost never prescribe antibiotics to either men or women. For a lot of the men that I'm seeing with acne, if I can't manage on topicals, I'll often try and lean towards isotretinoin relatively early, because we see that patients who end up on isotretinoin, they're often treated with antibiotics for almost years in duration. And so if we can identify those patients earlier, get them on really a definitive therapy for them, can potentially save them an unnecessarily exposure and get them better faster.
Absolutely. And I find myself doing that more and more recently. But I wonder if we can state some of the obvious barriers and why people do actually choose antibiotics over the other options. I think a lot of dermatologists are knowledgeable. They know that they have spironolactone, isotretinoin. Why do they pick the antibiotics and stick with it?
Yeah. I think you're getting, it's a little bit easier sometimes to just give someone an antibiotic and say, here you go, don't be careful in the sun if it's doxycycline, you might have some upset stomach, and I'll see you in a couple months and try and see if we can taper you off of it. It's a lot easier than enrolling someone in iPledge. And spironolactone, honestly, although it's a very helpful medicine, and we have some data that we can get into that shows it's probably quite effective, and maybe similarly so to antibiotics, it does have different counseling, and some dermatologists may feel less comfortable with it.
Yeah, actually, John, I think that's
a perfect.
Yeah, exactly. I was going to say it's a great segue. Why don't we talk about spironolactone? Just because, we've mentioned it enough times that even I'm salivating to learn more at this point about spironolactone. So,
yeah, and I think we should start maybe with the basics of how do you use it in your practice? I know, Raja, you have a very successful session at the American Academy meeting year after year about spironolactone. And can you tell us maybe how you use it in practice? And then we can also go over the side effects, because I think there's a lot of questions about that from patients.
Yeah, why don't you go ahead, John, because I think you've done a lot of work in this area. So
yeah, so my general approach, so we know spironolactone and hormonal treatments for acne tend to be a bit slower sometimes than other treatments like antibiotics and isotretinoin. And so I usually try and start patients at a dose where I think they're really likely to respond. So the situation I don't want to get into is we start them at a dose, and 2 months later they're not better, and they're not sure if the medicine's not doing the trick or they need a higher dose, and it's another 2-3 months. So I'll usually start them at 100 milligrams a day. I find that dose, most patients don't have much in terms of side effects, and we can get into what some of those could be. And I find it generally is pretty effective. And then if that works for them, I'll try and taper it down. But you'll see other people who will start them on 25 or 50 and then taper them up if they don't get enough efficacy on that dose. And either strategy I think is reasonable, but I personally like to start higher and then go down to try and help patients get better, see results, so that they're excited about the treatment they're getting.
And just to be clear, spironolactone is not FDA approved for acne at this time, but we have had a lot of experience. I think a lot of dermatologists, we're gaining experience in this area, so we use it off-label. But now, speaking of that, so sometimes when patients go into the pharmacy to pick up their medication, their pharmacist will tell them, hey, your blood pressure medication is ready. And they're like, I don't have blood pressure issues.
Yeah.
And so you kind of have to give them a heads up that you're using this off-label.
Yeah, I mean, when I introduce it to them, the first thing I say is, this medicine, it's originally made as a blood pressure medicine. It's a terrible blood pressure medicine. But it has these properties where it has anti-hormonal effects, and that's really helpful in treating acne, and that's how I introduce it to them. And then I hope when they go to the pharmacy, if they get told that, they understand where it's coming from.
So who do you think is an ideal patient to start with spironolactone? Give us a scenario of what is that patient that you're typically going to reach for spironolactone first?
Yeah, for me, often it's obviously usually a female patient, because if you give it to men, a small portion of them will get gynecomastia, and that's a really relevant side effect that really limits its use in that population. So female patients, I usually like them to be at least about 16 years of age. I tend not to treat people younger than that, but I know people who will. And then usually if they have acne that's a bit more inflammatory, more nodules and papules, less comedonal, if they haven't responded to topicals, those are patients where I start to think about it more. For me, it doesn't matter so much if it's on the lower face or the cheeks or the forehead. I mean, at some level, all acne is fundamentally driven at some level by hormones. So I find that it works well for all types of acne. I don't think it has to be patients who have it just on their lower face or that flare with their menstrual cycle, but certainly patients who have those characteristics tend to do well in addition.
That's an excellent point, actually, because I always thought that patients sometimes cannot remember. They can't pay attention to that detail. Does it really flare with my period? So I think that's a great point you're making. What about the blood test issue? Everybody is talking about that, and I know that there's new data, really strong data, supporting the unnecessary use of these blood tests. Can you guide us through that a little bit?
Yeah, so there's some nice data from Arash Mastaghini's group up at Brigham. They looked at almost 2,000 patients who were being treated with spironolactone, and they took a look at what happens when they're potassium checked. And really kind of the fundamental finding that they had was that there's really no difference from baseline in terms of potassium irregularities that were detected. And when patients who had abnormal levels, if they were rechecked, it was normal, and all of them were able to continue therapy. So it suggested from a clinical monitoring standpoint that it wasn't changing management in young, healthy women who weren't on other potential medicines that might interact with it. So most of our acne population, who tend to be young, healthy women who aren't on other medicines, who don't have a lot of comorbidities, suggests that we probably don't need to monitor them for potassium.
So why don't you tell us a little bit about side effects that you discuss with your patients, maybe the more common ones that you see?
Yeah, the most common ones I personally talk about are irregular menses and breast tenderness, which are relatively commonly reported, sometimes in up to 10, 20% of patients. Those tend to improve if they're on a combined oral contraceptive. So if they're already on one, that's a helpful factor. And in addition, if they're not, if they get those side effects, that's an easy thing to add on to help them out. It's also quite dose dependent. So patients who are treated 50, 100 milligrams tend not to have those side effects anywhere near as often as patients who are treated at higher doses, closer to 200 milligrams. The other side effects I talked to them about are orthostatic hypotension and diuresis, because of the medicine's original mechanism of action as a potassium-sparing diuretic. And I find those are quite infrequently an issue, but every once in a while you have a patient maybe who has low blood pressure at baseline who that becomes relevant for.
Yeah, I wonder, you may have to go to the bathroom extra time, but I never heard complaints about that so far.
I had it happen a couple of times, but it's quite infrequent in my experience, and in the literature as well, it's reported at about 1% to 5%. Then the last thing is, I talked to them about the black box warning, because that's another thing they're going to see when they pick up the medicine. And there are studies in mice where you give them huge doses, hundreds of times as much as you would use in people to treat them. And they do develop some various different types of tumors, mostly benign. And so because of that, I bring it up with them. Fortunately, we have several observational studies with almost 35 million person years of follow-up that suggests that the risk of gynecologic malignancies isn't particularly increased with spironolactone. We do need some better data in younger acne patients, but at least the data we have right now, both in mice at more reasonable doses and in humans in clinical use, don't seem to support that there's a real risk of malignancy.
And then, one thing I wanted to ask you about is with these new publications, you just had a JAD publication that's coming out, and you were looking at antibiotics versus spironolactone.
Yeah.
So can you elaborate on what you found in that particular study?
Yeah, we have two studies that use the same data set. We were looking in this Optum Insights Clininformatics Data Mart. So it's a claims data set. This is all observational data. It wasn't collected for this purpose. But we looked at patients who were started on either spironolactone or oral tetracycline antibiotics like doxycycline, minocycline for acne as their initial therapy. One of our first questions was, if you get started on one of these, what's your likelihood that your treatment gets escalated, that you end up on isotretinoin or another systemic treatment in the first year? Because if that's happening, that suggests whatever we started didn't work. And if you're able to stay on it, then it probably did as a surrogate outcome. And in that study, we really found there was no significant difference in the number of patients who switched to another systemic agent between those who started on spironolactone versus those who started on oral tetracyclines. So based on that surrogate outcome, it suggests the effectiveness in real-world uses might be pretty similar. The other thing that we looked at was, if you get started on it, how long are you able to stay on it? Because many patients, particularly women with acne, can be quite persistent into their 20s, even their 30s or longer. And so it's important to have a treatment with a durable response. And we know antibiotics, because of some of the side effects we discussed, we might not want to be on those for years and years. And so can spironolactone potentially be a medicine that has a good durable response where patients are able to stay on it? And using that same data set, we looked at patients who had been on treatment for at least a year. And the reason we picked that was we wanted people who are stable on treatment, people who are doing well enough to have been on it for a while. And then we looked at how long do they stay on it. And again, we compared spironolactone and tetracyclines. And again, spironolactone, actually here it looked much better. People were able to stay on it about 100 days longer. And the immediate thing you might ask is, well, we're trying to get people off tetracycline, so could that potentially bias it? And that was one of the reasons we picked that 1 year. If you're on tetracyclines for a year, you're not really following the guidelines at that point. So at some level, at that point, it's less likely potentially that you're stopping because of that issue, although certainly it's a limitation of this kind of study. But again, both of those studies and that data suggest that spironolactone at least seems to have similar, if not maybe better, effectiveness in women with acne and these populations.
John, it's publications like this that I think really make a difference for us in the clinic, because in the last 5 years, I've definitely, especially since residency, changed my practice. I used to reach for antibiotics as one of the first therapies. I would like to touch upon dietary modifications very, very quickly before we get there. But, with antibiotics now, when I think of adult women with acne or even teens with acne, I am reaching for spironolactone first line before I even think of antibiotics. I think there was a study that looked at using them both, and they had synergistic effect, and you can pull the antibiotics off, especially if I see a lot of papules and I see a lot of inflammation. I may add the antibiotics there, but I'm really reaching for spironolactone first line. I don't know how the two of you are approaching this, but I have a good guess on you, John, that you're probably going to spironolactone.
As I mentioned, I pretty much use it almost exclusively. I use the antibiotics in patients who need them, but patients do so well with spironolactone in my experience. And the data is nice now because you can say, we've looked at this and it looks like spironolactone does just as well as antibiotics in terms of getting you clear, but we know it has a potentially nicer side effect profile in a couple of different ways. So I'll usually go for that first. And you're right, sometimes I'll use an antibiotic in combination if we need to.
Yeah, thank you, John. And I want to second you, Raja. I think this study is very important because some practitioners out there may say, well, I want to wait for the randomized controlled trial, the head-to-head study. And I think we all know that study is unlikely to happen. So in those cases, that's where we need those large retrospective analyses that help us. And you mentioned the limitation of the study, obviously, but in the context of what we are studying, I think this is very good data to support our decision. And we know that it works in practice. So thank you for doing that. Hey, Raja, you know what I'm very excited about?
What's that you're excited about?
I'm excited about the Integrative Dermatology Symposium coming up on October 3rd through the 5th. This year we have an extra day, and it's going to be in the beautiful Coronado Island Marriott.
There's no question about it. And that program is going to be jam-packed with some really cool stuff. We're going to be talking about case-based discussions with multiple perspectives on things like psoriasis, atopic dermatitis. We'll also have workshops where you'll learn about herbal medicine and think about acupuncture. And so it's going to be a well-rounded program.
Yes, I encourage everybody to go to integrativedermatologysymposium.com to learn more about this great meeting. Before we go to dietary modification, I think we described well the patient that's well suited for spironolactone, but I wanted to ask you, what is the patient that you look at and say, this is the one who's not going to get spironolactone?
For me, if they're on medicines that interact
He's struggling with this question. Okay,
good.
That's
where I get a little worried. People who are on like
everybody gets spironolactone.
Other medicines
You get spironolactone.
It might put them at increased risk of side effects. That's a patient where I might not use it. I might try and use something else, or if I do, I'd monitor closely. And then in patients who have a strong family history of cancer or breast cancer, I'm very concerned about that on the black box warning. Even though I don't think it's a major issue, it's a relevant consideration just from a patient emotional standpoint. That you don't want to put them on something where they're having any second guessing themselves down the road that it might have been something that caused them a problem. So a patient who has a lot of concerns about that, I might still shy away from it for that reason.
They had a study in Asia where they looked at putting men and women on spironolactone, and a considerable amount of the men got gynecomastia. So I think for men, I'm wary about putting them on spironolactone because, honestly, guys just don't want to grow boobs and something that,
The other thing I do want to add is that a question that I hear a lot is, or a comment too, is that there are concerns about pregnancy with spironolactone. Something that always stands out to me is doxycycline, tetracyclines are really pregnancy class D. Like they have clearly documented harms in pregnancy. Spironolactone, there's a theoretical risk of feminization of a male fetus. It's never been shown. There's a recent review of literature published in JAD actually that again kind of reiterated that. So it's really a theoretical concern that hasn't been substantiated, and at lower doses in mice, it really hasn't been seen much either. And so from a pregnancy concern standpoint, honestly, antibiotics might be more concerning than spironolactone. So clearly you tell patients, you must not get pregnant on this. It's an important issue. But at the same time, that I think that concern is not so high as something that I worry about compared to other options like isotretinoin, like antibiotics.
Should we talk about dietary modifications? Because this comes up in clinic all the time. And when people are thinking about reducing antibiotic use, dietary modification will float to the top. And, some people, it takes them a little while to get warmed up to, say, isotretinoin or thinking about it, and they want to have other options. And I know you had a nice publication looking at even dietary modifications. So can you elaborate on, what your findings were?
So we talked about this. We recently published a review about trying to limit antibiotic use in acne. And one of the areas we covered was diet in acne, because it is a question that comes up all the time in clinic. And one of the first areas that I think the low-hanging fruit is glycemic index. So there are a couple of studies, even randomized trials, suggesting that low glycemic index diets can be helpful in the setting of acne. And honestly, low glycemic diet is probably healthy for anyone. And so it's a pretty easy thing to say, this is probably good for your overall health. In addition, it might help your acne. I think we see patients who say, I quit soda or things like that, and my acne seems like it's better. So I think you see those patients who kind of substantiate that evidence that we have too. The other things we talk about and that you hear about, and both from patients and when you're reading it, is milk, and that's complicated. There are studies kind of going both ways. One of the interesting things you'll see is actually whey and milk, and one of the things you'll see in clinic a lot is potentially patients who are trying to get strong, lifting weights, and they're doing whey protein. And a whey protein shake is like the equivalent of drinking about 5 gallons of milk. It's like a huge amount of whey compared to other sources. So that's a relevant historical fact to consider in the appropriate patient. And sometimes modifying that is another potential way to improve a patient's acne in a dietary manner.
I have had a few cases, this is personal anecdote, of course, where I've put people on isotretinoin and they're flaring through the first month, second month, third month. And I'm like, oh gosh, there's got to be something going on. Then I finally sit down and talk to them about their workout habits. And they're like, oh yeah, I'm taking whey protein. And then I usually tell them, hey, it's time to come off that whey while we're trying to get this isotretinoin on board. So
you definitely see that. And there's some good reports in the literature summarizing it too.
Yeah, there's a couple case reports where they've taken them off the whey and then the acne gets better and they put them back on the whey. And with that kind of a backing, I don't think there's going to be any RCT of whey in acne because it'd almost be unethical. But good point though. I didn't realize it was 5 gallons of milk. That's
Yeah,
quite a bit of milk.
I think 30 grams, like 40 grams of whey, which is kind of like a typical protein shake, is 6 to 12 liters of milk. So it's a huge amount of whey compared to other sources of it.
It's funny. There's also a lot of hidden sources of sugar when you're talking about high glycemic index. There was just another publication that came out that looked at not only sodas, but they looked at sweetened teas and unsweetened teas and fruit drinks. And turns out sweetened teas, even though they might be herbal, they sometimes contain more sugar than the sodas do.
Oh my
and
gosh!
So
yeah.
that's fascinating, and they found that was correlating to acne. Of course, these aren't causations; they're correlations when they do these sorts of studies. But clearly, high glycemic diet means looking across the board, and no question, if people are going to get healthier globally, I feel like that's a good option. I have had a few people that were going to go on to isotretinoin, and they modified their diet, and they got considerably better. That I was able to just keep them on spironolactone and diet modification.
Yeah.
Just kind of stay the course. It has happened. Not always, but it has happened from time to time. So I think this has been a really good discussion about spironolactone, antibiotics. John, any parting thoughts or practical tips that we should walk away with in terms of thinking about spironolactone and acne and antibiotics?
I think one of the key things, there's been, I think, a shift in the community towards more concerns about the risk, both at a population level and an individual level of antibiotics. And so I think bringing up alternatives to it's becoming an easier thing to do in clinic. And so I'd encourage people who aren't using spironolactone very much to read about it, to think about it. And I honestly personally believe that potentially flipping that ratio we talked about at the beginning, where we're using 5 times as much antibiotics and spironolactone in women, might not only lead to better patient outcomes in terms of improving people's acne and limiting their side effects, but also help us as dermatologists be better stewards in the community with respect to antibiotic use.
Thanks again, John, for joining us, and we appreciate your time today.
Yeah, thanks for having me. It's been great.
I'm going to go read because I thought your papers were excellent on this stuff. So I'm going to definitely give them a second read. Thank you very much for your work.
All right, thank you.
Thank you for tuning in with Dr. Raja and Dr. Hadar. This podcast is brought to you by LearnSkin, leaders in integrative dermatology education. Visit learnskin.com/podcast to explore our many programs. Subscribe today and never miss an episode.